Good afternoon, everyone, and welcome to our weekly COVID-19 meetings. We had a little bit of problem starting. There was a problem with people joining, but we've rebooted, and I think everybody is coming online, up to 181. So just to once again thank Project ECHO in New Mexico for allowing us to use the Zoom platform for these weekly meetings. And we've got once again a very good speaker today, looking at cardiology and COVID, and we'll hand it over to Graham to actually introduce the speakers. Just to remind you all, you're on mute, and towards the end of the talks, we'll open up the chat application for questions. Thanks very much. Over to you, Graham.
Thanks very much, Wendy. And my name is Graham Akers from the Department of Medicine at UCT, and we've got a very exciting program this afternoon. The usual format, an update on the epidemiology, the local epidemiology of COVID-19, and then our main speaker, followed by a panel discussion, and that'll take us to the hour. So I'd like to firstly introduce Andrew Bull from the Western Cape Department of Health and the UCT School of Public Health, who's going to give us a brief update on surveillance of COVID-19 in the Western Cape, and also some insight into the models that are being developed to predict the trajectory of the epidemic locally and plan for the effects on the health system. So over to you, Andrew. Thanks very much.
Thanks, Graham, and apologies that the date on the slide is from 2 weeks ago. I promise you the data are more up to date than that. If we can have the next slide, I'll try to. Okay, see, I've got the controls. Okay. So the last couple of weeks have just shown the dashboard just to give a sense of where we are with the number of confirmed cases, and increasingly we know that this is a massive undercount because of the lack of testing and diagnosis of cases. But those 16,500 is the number of confirmed cases. In terms of distribution, there's no real change. The Cape Metro is severely affected, and the majority of the cases are in the metro. And you'll see that the testing numbers have been fairly consistent for the last 2 weeks, and this really reflects the limit of testing capacity. And as a result, the tests have been more focused on clinical testing, and we've seen the proportion that are positive increase. The turnaround time on testing is sitting between 4 and 5 days at the moment, and there are a substantial number of tests that haven't been able to be processed because of this limit. So there's been an appropriate prioritization of testing for acute care settings, so hospitals predominantly, and some clinic testing. And the majority of those that have remained unprocessed have been tests from community screening and some primary care tests. But it does point to this particular constraint on the entire system, and there will be revised guidance on testing to focus testing on people where there's a clinical requirement for the testing or an outbreak response requirement for knowing the diagnosis. And so for participants who are sitting outside of acute hospital care settings, there may be some changes to guidance on testing. And we've shown these slides a couple of times, and the number of new cases on the left is really a reflection of the testing limit, that the number has been fairly consistent for the last 2 weeks or so. And you see on the right, with the lag of reporting, the increase in clinical cases, the turquoise being admissions, the kind of maroony color being deaths that have happened outside of an ICU setting, and the black being deaths that have happened in an ICU setting. There's been a continued quite high ICU mortality, sitting at 3/4 now in the public sector and 2/3 in the combined. And the ratio of ICU to general beds has been progressively going down Just for interest, the numbers of patients who've died with HIV and diabetes we reported it 2 weeks ago, and then Marianne Davies showed quite a detailed multivariable analysis of associations with death when we talked about diabetes last week, and we'll keep on updating that, but it does give a sense of the numbers. And then in terms of what it means for where we are and what it means for the platform, last week, the week ending Sunday, we had, if you look in the current admissions column, a total of 843 admissions across the entire province and 560 that were in the public sector hospitals. And by the end of this week, that number, if the trajectory continues as anticipated, should be sitting at around 1,400, and the week after that, 2,200. So we really are at the moment of massive, rapid increases in pressure on the clinical platform. And it's reflected across general care, ICU care, and mortality as well. So last week we measured 140. We had 140 deaths that were recorded. Now I had inserted 2 new slides, which unfortunately I sent too late. But the Medical Research Council Burden of Disease Unit has been tracking mortality for the whole province, and they've been able to discern these extra deaths at a population level as well. So what we're seeing on the clinical platform and what's happening in terms of death registration with Home Affairs are tracking very closely. And the value of that is, as we are less able to account for deaths on our platform because of out-of-facility deaths or lack of recording, it does mean that our vital registration may be able to give us a sense of what's happening with this aspect of the epidemic. The graphs at the top, the middle one just shows you where we are relative to where we're going. So it gives a sense of that we have this, that the week-on-week increases or day-on-day increases are still going to be most acutely felt in the next couple of weeks. Okay. And then I just thought I'd talk very briefly about the models that were released last week. So some of you may have heard there were media events releasing 2 national models, one by a consortium of essentially everybody who does infectious disease modeling, or most people who do infectious disease modeling in the country, who have cooperated around a national group coordinated by the National Institutes of Communicable Diseases, but including a number of different partners, including the MASHA group from UCT, who have been the group that have actually been running the model. And the Actuarial Society of South Africa released their first version of a model for the country. And what characterizes both models is an assumption of a very high proportion of patients being asymptomatic. And so all of their clinical events are assumed to only occur in the fraction of infections that are symptomatic. And that set of assumptions was made about 6 to 8 weeks ago, when data came out from a couple of studies showing a high undiagnosed fraction from serological studies, essentially. And it hasn't necessarily been substantiated by more recent serological studies. And if that assumption is too high, it would mean that it's underestimating clinical events. On the other hand, both models assume that the epidemic curtails due to herd immunity when 80% or more of the population become infected. And that assumption is also untested and unverifiable. We haven't seen that happen in other settings. And if that assumption is wrong, then it would mean we're overestimating clinical events. So it might be that those 2 factors could be balancing each other out, but it also might be that the first is wrong and the second is right. And if that's the case, everything that is being predicted may be an underestimate of what's to come. If that were the case, we would really be a tragic exception to anything that's gone before us in other countries, because these models, as they are, with these assumptions, are predicting a population level mortality of 1,500 to 2,000 deaths per million population, which only New York State at 1,500 at the moment is an example of a setting that has had that level of mortality. And then just on the last slide, what these latest models mean for the Western Cape. So the Western Cape is the only province that has province-wide public and private combined data available for calibration. So not in the public domain, but yet both groups have calibrated their models to the Western Cape. And so the gray line is pretty much the trajectory that we were following with an anticipation of hospital need, which included the excess field hospital capacity. The blue line is the official national model calibrated to the Western Cape, which suggests that we need to provide even more additional acute care over and above what has been provisioned for. And the orange line is the current version of the Actuarial Society model. So it does point to the fact that even with the extensive preparations that have been put in place, the current national guidance is that we still need to prepare more acute care capacity. And I think that was my last slide. Thank you very much.
Thanks very much, Andrew. Could I just ask one question about the final slide? It looks like there's exponential growth and then a reduction in bed requirements. And obviously that has happened in countries like Italy and in New York because of the introduction of a lockdown at that point in the epidemic. But why are you expecting that decrease in South Africa if we not anticipating the introduction of a lockdown again here?
So that curtailing happens because of herd immunity. That's with the assumption that a very high proportion are asymptomatic. The models can at the same time assume that the majority of the population is infected at that point, and that starts to curtail further infections.
It's an assumption that you're getting up to 80% at that point and then declining.
Yeah.
Okay.
But before that point, but as you start getting to reasonably high proportions of the population infected, it starts to affect your net reproductive number.
Okay. Thanks very much, Andrew, and thanks for that great update again. Really useful to see both the updated numbers, but also the different dimensions that are presented each week to give us a better understanding of all the data. So to move on to our main talk for today, it's really a great pleasure to introduce another international speaker. So just by way of background, I think from the very first clinical reports of COVID-19 from China and Southern Europe, it was clear that this was not a disease restricted to the lungs, and there was multi-system involvement, and probably the most important additional organ system involved was the cardiovascular system. But we've only gradually been gaining increased insights into what way the heart and the vascular system is involved in the pathogenesis of COVID-19 and how it contributes to mortality. And to give us greater insight into that today, we have Giulio Stefanini from the Humanitas University in Milan, Italy, who's been working in the clinical setting in patients with COVID-19, as well as researching this issue, and has published some important papers in this regard. So Giulio is an interventional cardiologist and a cardiologist with special interest in acute coronary syndrome and valvular heart disease. He's an associate professor of cardiology at the Humanitas University in Milan, works as an interventional cardiologist there. He also serves as head of clinical research at the Cardio Center for Humanitas Research Hospital, and has a PhD in experimental medicine and an MSc in health economics and outcomes and management in cardiovascular sciences from the London School of Economics. So it's really a great privilege to introduce Giulio today, who's going to speak on the topic, how does COVID-19 affect the cardiovascular system? So thanks very much, Giulio, and we look forward to hearing your talk.
Well, good afternoon, and thank you, Graham, for this introduction and for this invitation. It's a true pleasure to have the opportunity to share my opinion and data with you. These are my, oops, how does this work? I should have control of this slide, but I do not know how to. go ahead and change slides. Let's try again. No, it does not work. How do I change this? Okay. These are my conflicts of interest. I don't know how to control the, oh, here, now it should work. But it's going crazy. I am not able to control it. Let's see. It's out of control. Please help me. I am not in control of my slides. I ask your help.
Julio, you can control the slides. It's fine. You can just proceed. We are seeing everything.
It's skipped 2 slides. You see, I did not push anything and it went ahead on its own.
Yeah. We'll control your slides. Just tell me when to make the next slide, please. We're on your third slide at the moment. Please continue.
No. Give me control. I would prefer to do it on my own. It's just not working if you control it remotely. It's not very smooth to present it this way. I don't know. Is it possible just to share my screen? I think it would be easier.
I will hand over share control to you, Julio. Just hold on, please. Julio, we best continue to share from our side at this stage in the interest of time before I make that switch. Are you?
Okay. So let's try. I will try to just do it this way. Anyway, you are all very much aware that we were heavily involved in the COVID-19 pandemic. We were one of the first regions involved in the pandemic in Europe. And as a matter of fact, you see the numbers in this slide. Specifically, this is not the entire Italy, but the Lombardy region, which is located in the north of Italy. So our healthcare system was heavily involved since day one. I should change slide. To face the emergency, we had to reorganize significantly our cardiovascular services. And we shared actually our experience in this paper in Circulation published in March, mainly sharing our changes in organization with respect to the management of elective patients, as well as the management of the cardiologist's activities, with specific aims which were to provide a continuous care to patients and at the same time take care of the safety of healthcare professionals. So since the very beginning of the epidemics, it became clear that the cardiovascular system was involved. In the first couple of reports from China, 2 pivotal papers, one published in The Lancet and one published in JAMA, it was quite evident that the prevalence of coexisting cardiovascular diseases was high, and not only that it was high, but also that it was associated with worse outcomes in terms of survival and access to the ICU. And these data were actually confirmed by a extremely relevant paper published a few weeks back in the New England Journal by Mandeep Mehra, in which mainly in an analysis from almost 9,000 patients from 169 hospitals across the globe, it became quite evident how the presence of underlying coronary artery disease and coexisting heart failure were strong independent predictors of mortality. So trying to summarize the first part of this talk, I wish to underscore the fact that indeed the presence of coexisting cardiovascular disease is quite frequent in this population, and they appear to play a role in terms of prognosis. Another aspect that became clear from the beginning was the role of cardiac injury. As a matter of fact, we had 2 reports published in JAMA Cardiology at the end of March, underlining how the presence of cardiac injury in patients with COVID-19 was associated with an increased risk of mortality. Actually, we tried to confirm these findings in our own setting by analyzing our patient population here at my hospital. And we indeed observed that the presence of elevated cardiac biomarkers, both troponin and BNP, was strongly associated with mortality. And what we also looked at was the temporal relationship between the increase in biomarkers and the death event. And you may appreciate from the right panel of this slide that there appeared to be a temporal relationship. So there was not an immediate association of the increase in biomarkers with mortality, but this increase was rather preceding the mortality event. What we did was also to evaluate whether troponin and BNP could play a role for a early risk stratification of patients with COVID-19. And what we did was to stratify the patient population based on an early detection of cardiac involvement, meaning an elevation above the upper limit of normal of troponin and BNP at the time of hospital admission. And you see the results in this slide. We observed that the patient population with both troponin and BNP increased had an extremely high risk of mortality throughout a follow-up of 20 days, and that the increase of both troponin and BNP concomitantly was associated with a 3.6 increase in the risk of mortality, so a strong independent predictor of mortality. Having said this, I think that the following question to ask was whether this myocardial injury was actually associated with mortality due to a general deterioration of the patient, or whether it was actually indicated an underlying cardiac damage with cardiac dysfunction. And we tried to answer this question in a patient cohort that included patients from my hospital, from another hospital in Milan, and a few hospitals in New York. And what we did was to set up a cohort of more than 300 patients with complete cardiac characterization in terms of biomarkers as well as ECG and echocardiography. And what we observed was that actually patients with cardiac injury had changes on the echocardiogram. Specifically, we observed some specific phenotypes like a global LV dysfunction, wall motion abnormalities, diastolic dysfunction, and right ventricular dysfunction, as well as pericardial effusion, probably underlying the fact that there are different mechanisms that play a role on a pathophysiological standpoint with respect to the involvement of the myocardium. At the same time, we observed that those patients that had both a myocardial injury and the presence of echocardiographic abnormalities had the highest risk of mortality. So trying to summarize the key points of the second part of my talk, myocardial injury is associated with cardiac abnormality. Transthoracic echocardiography allows to characterize the phenotype of myocardial injury and to optimize risk stratification. Certainly, treatment strategies could be intensified in patients with evidence of cardiac involvement. However, it's quite clear that the mechanism, the pathophysiological mechanism of myocardial injury in COVID-19 patients still needs to be fully elucidated. Another aspect of these patients on which I focused was the acute myocardial infarction in patients with COVID-19. The reason was that since the very first days of the pandemic here in Milan, I myself, as well as some colleagues working in other hospitals, had to face the presence of patients with ST elevation myocardial infarction who showed up at their hospitals, and these patients had concomitant COVID-19. So we actually decided to share our experience in a case series, which involved all the hospitals with a cath lab in the Lombardy region. Finally, 28 cases were shared from 14 hospitals. And these were cases of ST elevation myocardial infarction in confirmed COVID-19. In the following slide, let's see if I managed to go ahead. In the following slide, you will see I need to go one behind. Anyway, these patients were patients with a very typical presentation. Unfortunately, the slide was skipped. Here it is. In terms of baseline clinical characteristics, you see that the prevalence of cardiovascular risk factors are very typical for an ST elevation MI population. 20% had a prior myocardial revascularization and 10% had a prior MI. What I think is most relevant is that 24 out of 28 patients actually did not know to have COVID. So their acute myocardial infarction started in an out-of-hospital setting, and these patients showed up with ST elevation MI as a first clinical manifestation of the underlying COVID-19 pathology. In terms of symptoms, the majority of patients had typical chest pain. There was a clear localized ST segment elevation in 25 out of 28 patients, while the remaining 3 had new onset left bundle branch block. And in terms of echocardiography, the majority of patients had a localizable motion abnormalities rather than diffuse hypokinesia. The angiographic findings and clinical outcomes are summarized in the next slide. Let's see if the system brings me ahead of one slide. Okay, let's try again. What we observed, which was quite striking, is that in a patient population that indeed presented with typical ST elevation MI, well, in 40% of patients, there was no culprit lesion. So the coronary arteries showed non-obstructive disease, which is quite striking for a typical ST elevation MI population. On the other side, we observed that clinical outcomes were very unfavorable in these patients, in the sense that the mortality at 12 days was 40%, very high for an acute MI population nowadays, underlining the fact that actually the cardiac involvement is determining a terrible prognosis in these patients. So the way I wish to summarize this third part of my talk is that indeed an ST elevation MI may represent the first clinical manifestation of COVID-19, that in approximately 40% of COVID-19 patients with ST elevation MI, the culprit lesion is not identifiable by coronary angiography, and that the risk of death in these patients is excessively high, which confirms the prognostic relevance of cardiac involvement in COVID-19. As a matter of fact, as you will see from the following slide, we tried to delineate specific pathway for the management of ST elevation MI in the setting of COVID-19. As here you see the proposed algorithm by an ESC task force in which I had the honor of participating. And we published actually this algorithm in the European Heart Journal a couple of weeks back, mainly suggesting specific pathways for the management of ST elevation MI in the setting of COVID-19 outbreak. Of course, this applies to regions with a heavy involved in the outbreak. This does not apply to any kind of geographical region that has an experience of COVID-19, but only to those healthcare systems that are heavily involved. And I wish to go to the last part of my talk, which focuses on the impact on non-COVID patients, which I think it's a very relevant population. As a matter of fact, the COVID outbreak had a substantial impact on our regional healthcare system organization. And on a national standpoint, the experience was published in the European Heart Journal a couple of weeks back. And what happened is that with respect to acute MI patients, there has been a dramatic reduction in the number of those that present in the emergency department nationwide. And what I find very worrisome is that this reduction in the number of acute MIs that showed up at the emergency department is paralleled by an increase in out-of-hospital cardiac arrests. And these data were actually published in the New England Journal. You see them in this slide. This is an out-of-hospital cardiac arrest registry from a large area within Lombardy. And what the authors did in this paper was to compare out-of-hospital cardiac arrests in 2019 and those observed in 2020. And you may appreciate a dramatic increase in the numbers during 2020, suggesting that the reduction in acute MI that presented the emergency department is paralleled by an increase of out-of-hospital cardiac arrest. So there is some kind of barrier for patients with an acute cardiovascular problem to show up at the hospital, which actually is a public health problem at the moment. On top of this, the reorganization due to COVID also had an impact on elective patients. So you see in this slide, the elective cardiovascular procedures performed at my department during the months of February and March, and you may appreciate that there was a progressive reduction and finally a complete interruption of these elective procedures. And of course, some of them were done in patients that required an urgent intervention. So we had to postpone also those patients that were requiring an urgent or semi-urgent intervention due to their underlying chronic condition. And this also has an impact that will need to be evaluated. And finally, I want to share with you this slide, which instead summarizes the effects of COVID-19 on outpatients visits and diagnostic tests performed in my hospital in 2019 and 2020. And also here, you may appreciate that for ischemic heart disease and heart failure clinics, there has been a significant reduction in the number of outpatient visits and the number of diagnostic tests in 2020 as compared to 2019. And I mean, these patients were left behind, and we will need to implement adequate strategies to take care of them in the next few months. So trying to summarize this last part, we observed a reduction in acute MI presenting for care, an increase in out-of-hospital cardiac arrest related to the COVID-19 outbreak. And at the same time, there was a reduction in healthcare provision for patients with chronic cardiovascular diseases. And this certainly may have potentially dramatic public health implications, which will need to be addressed. I thank you for your attention, and I hope that the presentation was smooth enough despite the problems with the remote control of the slides. I cannot hear you.
Hi, Julio. Sorry, I was trying to unmute myself. I was having the same technical difficulties you were having. So thanks very much for that presentation. It really highlighted all the key aspects of the impact of COVID-19 on the cardiovascular system and importantly, some of the mechanisms. It really does leave us a lot of time for questions and discussion as well, which is really great because we're going to move on to the panel discussion. So our panel is made up of two colleagues, Mpika Nseche, the head of cardiology at Groote and UCT, and Mark Mendelson, who's head of infectious diseases at UCT and Groote. I'm going to give Mpika the first chance to ask one or two questions and make some comments, and then move on to Mark. And just to highlight that we will be able to take questions from attendees on the webinar. If you just type your questions or comments in the chat function, and Mark Sondrup will pick those up and present those to Julio after the panelists have had an opportunity to engage in discussion. But Julio, before I hand over to Mpika, I just wanted to ask you two brief questions. The one was, you presented that the mortality rate for those patients with ST elevation MI with COVID was close to 40%. And I just wondered how that compared to patients presenting with ST elevation MI in your setting prior to the COVID epidemic.
Well, it compares very unfavorably. Our 30 days mortality for patients with acute MI is way below 5%. So I have to say that it compares extremely unfavorably. Of course, it's not given that these patients were dying only for their cardiovascular problems. It was a concomitant problem. I mean, these are severe compromisation related to COVID in terms of respiratory aspects. And at the same time, they had the problem of an acute MI, which probably increased their risk in a significant manner, leading to a final exodus.
So it's about a 10-fold increase in mortality risk, yeah. And then just the second question was, you showed the echocardiographic abnormalities during acute COVID, and I just wondered whether yourselves or anybody else has looked at repeating echoes in those patients who've recovered and whether some of those abnormalities resolve, suggesting that it's an acute decompensation.
Well, that's a good point. As a matter of fact, of course, this was a retrospective registry, so we had the data that were available and that were acquired in clinical practice. We only included those that had a complete echocardiographic assessment, so not point of care echocardiography. And we assessed the cardiac involvement at that point, but we did not have sequential assessments. So it's difficult to say whether they recovered. On the other side, I think that this underscores the need to delineate follow-up plans for these patients, since those that had a cardiac involvement will need to be evaluated to see whether they will have cardiovascular complications during time. So we are doing this in my hospital. We set up a program with echocardiography at 1 month, 6 months, and 1 year. And we also are planning to do cardiac MRI at 6 months in patients with the most severe cardiac involvement during hospitalization. And I think that, it's very important to understand what is going to happen in these patients and what their cardiovascular outcomes will be in the mid and long term.
Great. So I'm going to hand over to Mpiko now. And Mpiko, it might take a few seconds to unmute yourself.
Can you hear me?
Yeah, we can hear you fine. Yeah, over to you.
All right. Julio, thanks for a great talk. Really appreciate it. I just wanted to start out by saying our commiserations for the loss of so many of your compatriots, but also to say congratulations really for finding the time and energy to conduct the research and share your experience both in publications and presentations like this. It's hopefully going to help us with management of our patients down here. Julio, I wanted to I've got 2 questions. The first one is in 2 parts. You mentioned that in 24 of the 28 patients that you had published, that the ST elevation was their first manifestation. So I wanted to know what the reason was for testing for COVID in those patients presenting with ST elevation. Was it routine that everybody got tested, or was there something else that triggered you to test for COVID?
So we had a plan to, during the month, since March, we started to test all acute MIs that showed up at the hospital. And this was the reason to test. We had some early cases in which this strategy was not implemented yet. And the reason to test was the fact that these patients were or coming from areas at risk or had additional symptoms that triggered the suspicion of a underlying COVID in these patients.
Okay. And do you have any information whether...
Meaning typically fever. Most of these patients had a history of fever during the prior days.
They did subsequently. Okay, great. And the second question relates to, or the second part of the first question relates in part to what Graham was talking about. So in the 40% of patients that had no obstructive coronary disease, all right, did you look further for features of stress cardiomyopathy, for viral myocarditis, Takotsubo? How did you explain the presentation?
So unfortunately, the setting in those days did not allow us to further investigate these patients, since we had to keep clean pathways and avoid the diffusion of the virus in an excessive way in the hospital. So they did not do anything more than echocardiography. And let's say that we labeled them as MINOCAs. However, what my belief is that there are different pathological mechanisms that might have played a role in determining this ST elevation MI mimic. And these might include a direct involvement of the myocardium from the virus, so myocarditis, but it also could be a vascular problem in terms of vasculitis and with or without endothelial dysfunction, which might also have played a role. And finally, there could also be a underlying, let's say, type 2 MI related to the COVID-19 disease. However, I have to say that it's very atypical for a type 2 MI to present with ST elevation.
Okay, great, thanks. And then I want to come back to the issue around biomarkers and the troponin and BNP. And as you know, there's been much debate and discussion about their role in patients with confirmed COVID. You nicely showed us that it can be a very useful risk stratifier for patients with a poor outcome. But at a practical level, in terms of helping you with diagnosis and treatment strategies, you know, for example, differentiating pulmonary edema from COVID pneumonia in patients that could have both. Was there a place where these biomarkers on a practical level could help?
I think it's a very good question. I think that, you know, of course, I see it from the cardiologist's perspective. And I have to say that this disease cannot be seen from a single perspective. A multidisciplinary approach is essential for the management of these patients. Since, you know, it's not only a cardiovascular problem, it's not only a pulmonologist problem, it's an internal medicine problem. And of course, I focused on cardiac biomarkers because I'm a cardiologist, and it was interesting to see how other colleagues that come from other specialists had their focus on different biomarkers for risk stratification. And probably, you know, we need a more holistic approach. Having said this, it's also true that BNP and troponin are diffused assays. They are done in almost every single hospital, and they're relatively cheap assays. And undoubtedly, we have evidence suggesting that their use for an early risk stratification may be helpful to identify those patients that require more intensive treatments. They're the only way I see their use. So it's truly a risk stratification. It's not an evaluation of cardiac involvement. I think that they're more useful for risk stratification.
Okay. Thanks. I'll hand over to Mark. Come back.
Right. Thanks, Mfika. So Mark, you're on the call. Interested to hear your inputs and questions that you had for Julio.
Thanks very much, and thanks, Julio. In fact, a number of the questions have been covered. So I'd like to take you back to the pathophysiology. You said it's still to be elucidated of the global LV dysfunction and the other three abnormalities you just defined. I mean, can I push you a bit and try and get your thoughts on this? And particularly, I wondered whether there was any help that could be sought from SARS in 2002 or MERS, other coronaviruses, whether you're aware of any studies that might point to that. And my second question, I guess, is linked. I mean, we're, like you and everyone else globally, are seeing some patients deteriorating extremely rapidly. And, you know, predominantly, of course, we're all focusing on the respiratory system as, you know, the hypoxia is getting worse, but some of them are very, very rapid. And we think that you know, pulmonary circulation and thrombosis may be playing a part. But I mean, did you identify any ECG changes or anything that could really help give some indication of whether the cardiac deterioration was in part playing a role there in these rapid deteriorations? Thanks very much.
Good. So I start from the first part. So the experience from SARS and MERS, well, there is evidence published that indicates the direct involvement of the myocardium in terms of myocarditis in the case of SARS. And I think it's interesting because it might be a mechanism that plays an important role also in COVID-19 patients. Having said this, what I also find interesting from SARS and MERS is indeed the long-term follow-up. I have been reading some interesting reports from a 10 or 12 years follow-up from patients that survived SARS in Toronto. And what they observed were cardiovascular complications, specifically metabolic complications, in a significant proportion of patients during long-term follow-up. So again, underscoring the role of defining follow-up programs for these patients. So the second question was whether I have seen or not a cardiac involvement that has played an important role in the rapid deterioration of patients with COVID-19. As a matter of fact, it's very difficult to discriminate whether it was a cardiac involvement or whether it was predominantly a pulmonary deterioration, or also whether the kidneys were the first to suffer, so acute kidney injury. I think that overall what we observe is a deterioration which involves certainly these three districts in an important way. Whether the cardiac deterioration plays a major role, well, certainly I had this perception in some patients. However, it's very difficult to state strongly that this was the main problem of these patients.
Well, thanks very much.
Okay, thanks, Mark. So I'm just going to check in with Mark Sundrup as to whether there are any questions coming through the chat function for Julio.
Graham, thank you very much. There are quite a few questions that have come through. The first set that I'm going to perhaps pose to Andrew Boole, so we get those out the way. There have been a number of ones with similar themes, but perhaps the one that's a bit of an outlier. Andrew, there was a question from Dr. van Skype wanting to know around the backlog of specimens at the NHLS, if it's still in the vicinity of around 16,000, and are they ever actually going to be tested, or have we decided to terminate that? Perhaps they can go to Mark Mendelsohn as well if needs be. And then just to get back to the modeling issue, two questions around that, Andrew. The one is that the model there predicted between 9,000 and 14,000 deaths. The question from Dr. Durant was whether it was out by a factor of 10. Should it be 90? Is it 90 to 114,000? And then if you can just please again cover the two major reasons as to why there would be potential inaccuracy in the current modeling. Andrew?
Okay, so on the backlog of tests, I think it's in the order of 16 to 20,000. One of my colleagues may have better information about which ones may still be processed. And then on the modeling, the numbers are for the Western Cape, not for the country. And yeah, I certainly hope they're not out by a factor of 10. There are some much more.
Andrew, I think you know, the 9 to 14,000 is correct. I think that's intended.
Yeah, correct. And then on the two main reasons, the one being that in order to have an epidemic that rises as rapidly as this one, we have to be assuming a reproductive number of reasonable size. And if one has that in a completely susceptible population, then one gets then it's most models will show that most people will get infected unless you make some assumptions about differences in risk, which the models don't have the complexity to make. So in order to get mortality and hospitalization estimates that have some plausibility, they've made an assumption that it must mean, therefore, that the majority of people getting infected are asymptomatic. And some weeks ago, that looked like a plausible assumption because there were a number of studies showing that when you did serology, you found a whole lot of people that were asymptomatic or pre-symptomatic that weren't picked up by symptom-driven testing. But more recently, in countries and regions that have had very high levels of morbidity and mortality, they haven't seen high population levels of seroconversion. So that may have been an assumption that was optimistic. And then the other one was just that the notion that everyone, that an infection like this would move through homogeneously through a population, those low levels of seroprevalence might not be only due to lockdowns and interventions and behavioral change. They may also have to do with some heterogeneity and risk, which hasn't been fully described or accounted for in the models.
Thank you very much, Andrew. Graham, there are a number of questions for Julio. Maybe I'm just going to start with the one that asks about potential mechanisms for this increased cardiovascular risk, morbidity, mortality with COVID-19. Is it really just related to the concomitant issues of obesity, diabetes that we already know, hypertension, or is there something else perhaps that could be plausible? There's a question from Jeff Dusheko saying the Mira paper in the New England Journal suggested a benefit from statins. We can just have your thoughts on that. And whether then also with respect to patients having myocardial infarctions, what percentage of them actually ended up requiring ventilation who had concomitant COVID? Maybe I'll just leave with those three at the moment.
Okay, so starting from the first one, it's difficult to say whether there is some other mechanisms that determines a higher susceptibility of patients with concomitant cardiovascular diseases. What is sure is that we are observing this. So we are observing a high prevalence of coexisting cardiovascular disorders in patients with COVID-19, and particularly with those with the worst prognosis. It might simply be that those patients are the one at highest risk due to the concomitant comorbidities, which probably is the most simple explanation, but sometimes the simple answers are the correct ones. The second question was whether how many patients of our STEMI cohort required ventilation, and this was a very high prevalence. I think 60 or 70% finally required ICU admission and ventilation. And the third question, I don't remember it now.
Julia, I will get to the third question around statins, but I wonder if I can just cotton on, because there's a question around of the patients with MIs, apart from requiring ventilation, someone asked about concomitant acute kidney injury. Was that a significant feature as well? Before you answer the statin question.
So the concomitant kidney injury also plays a role. I think that the cardiac injury and the kidney injury both play a role, certainly through different mechanisms, but this is a problem in the patients that we observe. And regarding statins, it's true that the signal is there. However, I would be very cautious, since we need a clear hypothesis to evaluate whether this signal is robust or not, and whether it has a true effect, whether the effect that we observe is true. Look at what happened with all the story of ACE inhibitors and ARBs, which initially led to some safety concerns based on not much. And what we finally observed in the large experience published last week in The Lancet is that apparently they do not play a role. We actually, actually, they do not increase the risk of the disease. On the other side, I have to say that we also have some data there, some small scale data, in which we try to provide some more information compared to the New England Journal article that covered the topic on ACE inhibitor and ARBs. What we observed was not only what was going on with those patients that had a prior therapy with ACE inhibitors and ARBs, but also to split them according to whether they discontinued these drugs at the time of hospital admission or whether they continued these drugs during hospital stay. And what we observed in this small-scale study that it should appear in print in the European Heart Journal Cardiovascular Pharmacotherapy in the next couple of days, what we observed was that those patients that continued their therapy had an apparent protection in terms of mortality, not only compared to those patients that discontinued, but also to those patients that did not take ACE inhibitors and ARBs at all, and without observing differences in pressure control. So pressure values were comparable across the three groups, but there was a mortality benefit, hypothesizing that there could be another mechanism that favors those patients that are taking RAS inhibitors in the setting of COVID-19. But of course, this will need to be proven by prospective randomized controlled trials.
I can just
out of interest, sorry, Mbika, just to pick up on that, what was the magnitude of that effect that you're going to be publishing?
Sorry?
The magnitude of the effect.
Well, quite relevant. Of course, we're talking about a 400 patients population, but it's a very relevant effect with a 50% relative risk reduction. And what is interesting is that the effect is further pronounced after adjustment for several covariates. Of course, again, we are talking about a small population, but I think that it's of course hypothesis generating and interesting in that sense.
Sorry, Mbika, you want to come in?
Yeah, I was just going to add, just to go back to the question around why patients with underlying coronary disease and cardiovascular disease might be much higher for mortality, and is it just the obesity and diabetes? I think in most of the analyses that show that the obesity and diabetes and these other underlying risk factors have been controlled for, so it's independent of those. But I think it's also important to remember that if you've got underlying structural heart disease and you get another insult of any variety, whether it's infection, blood loss, whatever it is, that you've got very little wiggle room and ability to compensate. And so outcomes tend to be poorer in patients with underlying structural heart disease to begin with. I think the real question is COVID any different? So is there an additional hit with COVID above and beyond what one might anticipate in patients with underlying structural heart disease?
Well, it's a good question, Pico. I think it's a very good question. Whether this is, well, it's a question to which it's difficult to answer.
Yeah. A rhetorical question, in a sense.
A rhetorical question. On the other side, I could say that in this case, in those cases that we observed with cardiac dysfunction, in which we performed echo in the series that I showed you, it's difficult also to say whether this cardiac dysfunction was present already, whether it developed during COVID. So in that sense, also speculate that actually those patients were having an increased risk due to the underlying cardiac dysfunction. It's very difficult, I have to say. Of course, it would be, these are all questions that would be interesting to investigate, but it's difficult also because luckily the number of cases is reducing. So it's more and more difficult to set up prospective studies on the topic. I think that we should rather focus on the long-term cardiovascular complications in these patients, hoping not to see second waves.
Mark Sundrup, there's one additional question, is there?
Right, Graham, I thought we would just have this one because I think it's an overarching broad question. Just to say that we've real-time had the, on the chat before I asked the question, that NHLS has indicated any swab marked urgent will be prioritized. But Julio, there was one question being asked that the world has seen that healthcare workers have disproportionately been affected in Italy. Do you have any final parting words of wisdom for those of us down south?
Sorry, I missed the question.
Healthcare workers have been disproportionately affected in Italy. So do you have any parting shot for us?
Yeah, actually, this is not completely true, to the sense that we now start having the first studies on serology, so EGM and EGG, and specifically on healthcare workers. For example, in my hospital, which was quite heavily involved, we observed only 6 or 7% of healthcare workers that developed a immunological response to the virus, meaning that only a minority of them were exposed to the virus in a significant way. And this prevalence increases, but not too much, in other areas within the region that had a more heavy involvement, such as Bergamo and Brescia, in which they paid a high price in terms of mortality. But in terms of healthcare workers' infection, they do not reach 20%. So what I want to say is that according to these data, which will need to be, of course, confirmed by other studies, the PPIs that were used were effective in protecting the healthcare workers. But of course, you know, these are preliminary data. I have seen the first few reports now during these last couple of weeks, so it's difficult to have strong conclusion at this point in time.
Okay, so we've reached the hour, and just to end off with, to say thank you very much to Julia for the time, your sharing your experiences and your research and your insights. I think the discussion section has been very enlightening and ability, you know, given us the opportunity to kind of gain better insights into this important aspect of COVID-19, the cardiovascular aspects that, and I'm sure with time, with further research done in Italy and in other parts of the world, we will gain increasing insights into the mechanisms and the contribution that it plays to the pathophysiology. So thank you very much, Julia. Thank you to Andrew for the update, and to Mpiko and Mark, the panel members. And just to say, we will be holding our next webinar on Wednesday next week, back to our usual time of 4 p.m. And the plan for next week is a radiology session. Kanita Said-Hartley from Grooteskier will be discussing some of the radiological features on chest X-ray and CT scan of COVID-19, with some cases presented by clinical colleagues at Grooteskier to illustrate some of the important radiological findings. So back to Mark and Wendy, and thank you for participating in our webinar this afternoon. Thank you very much.
Thank you.
Thank you, everybody. We'll see you next week, and the recording is available online. Thank you to everyone.
Cheers. Thanks, Julia.
Thanks, Julio.
Thank you. Bye-bye.
Bye.